Hello friends, I am Dr. Harsh Mathur from Om Netralaya, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended and not meant for children. So this is a fairly routine case in S2 to 3, but at the end the IOL was not centering and it was difficult to maintain the chamber. So in a while we'll see what was the problem and how it was sorted out, and by then let's go through this video. So by now the side port has been made, phenocane injected, the capsule is stained with the dye, and the chamber is maintained with the 1.4% sodium hyaluronate. Now a triplanar incision is being constructed, barely nicking the limbal vessels, and with a 2.8 mm keratome we enter the anterior chamber, and with a 20 gauge MVR another side port is constructed, and with a 5.5 mm marker a mark is made over the cornea which will help me guide the rhexis. So the aim is to get at least a 5.5 mm of rhexis, and it is created with the help of a 26 gauge bent cystitome, and we have got a fairly round rhexis. Now is the time to do hydrodelineation. So a gentle wave of fluid is injected and then the opposite pole is pressed so that the fluid behind comes out, and now a continuous wave of fluid is injected till the pole of the nucleus prolapses out, and that's it. One pole has prolapsed out. Now coating the endothelium with a high visco and then gently dialing the nucleus in the desired position. And now is the time to take the phaco probe in. It is a Cataracts 3 phaco machine. The nucleus is held by a vacuum in the center. The karate chopper goes behind and we get a good crack and 2 heminuclei. Now the 1 heminuclei is slowly nibbled and it goes and gets emulsified in no time. So at the moment the proximal heminuclei has gone back in the bag. So this nucleus is being emulsified more or less at the plane of the iris, and now the second nucleus is held and divided into 2 heminuclei, and the one quadrant is removed. So I am being in the central safe zone at the plane of the iris. So, and as the endothelium is protected nicely, now the parameters are reduced, the chopper goes in the safe position, and the last bit of piece is emulsified, and that's it. The nucleus is managed in no time. A bit of hydro is done over the cortical matter to loosen it up. The jet of fluid is injected. The chamber is maintained with a HPMC, and now with the help of a bimanual irrigation aspiration the cortex is removed. Now is the time to switch the hands. So while doing topical phaco, my bimanual irrigation aspiration is very helpful, as the position of the eye can be maintained in the primary gaze and the patient doesn't move his eye or is not able to move his eyes, and that's it. The cortex is taken care of, and now is the time to inject the IOL. So it's a hydrophobic IOL. The optic is tucked in the groove, and then the haptics are tucked inside the groove, and the injector is closed, making sure the whole part of the IOL is in the groove. Now the wound assisted IOL implantation is done. The leading haptic goes in the bag. And then the trailing haptic is dialed in. And now is the time to thoroughly wash the viscoelastic substance. Now with the irrigation probe, the jet of fluid is stream of fluid is injected in the anterior chamber, and the visco is flushed out from behind the nucleus. And now with the bimanual irrigation aspiration, the remaining visco is removed. So by now the case is looking great. The IOL is looking centered, and once we clean the viscoelastic substance thoroughly, now is the time to close the wound. And just look now, the moment I do hydration, you can see that the optic is there, but the haptic is not in the bag. So now again I have to fill the anterior chamber with viscoelastic, and then again this IOL is dialed. And now once this haptic goes in the bag, immediately the chamber is maintained, the pupil is round, and now again, since we had to fill the chamber again with visco, now is the time to remove this viscoelastic substance from the anterior chamber. So one has to make sure that the IOL is completely in the bag. Most of the times while we are going behind the IOL and cleaning the viscoelastic substance, the haptic comes out of the bag, and if we are not careful and we leave it the case like this, then there can be irritation of the iris and UGH syndrome can occur. So now a bit of moxifloxacin is injected and the final hydration is done. So the lens is nicely in the bag now, and the case is concluded. Hope you like this video. Thanks for watching.